Great. Hello, everyone. It's a privilege to be with you. Paul and I are very excited. We both love to listen and learn, and we're excited to partner with you on revealing some of the things that we've discovered together in our journey to CareOregon. And that's a great lead-in to tell you just a little bit about where we are currently serving. So in Oregon, CareOregon was founded in 1993 as a nonprofit, founded by doctors and hospitals to help them take care of the Medicaid population. Over the years, we've grown to about 300,000 members, which is really about 25% of all the Medicaid in Oregon. Our foundation of who we are is this idea of focusing on building individual well-being in a community health setting through shared learning and innovation. It's out of that spirit and framework that we're going to reveal to you what we've been hearing around the space of medications from our patients and members, from our pharmacists, from our community settings. And so really our vision is healthy communities for all individuals, regardless of income or social circumstance. And we have the privilege of doing that work in both the rural and the city locations, and all the dynamics that creates in serving our people come to bear on some of the pearls that we'll be sharing with you today. So the first thing that, in the spirit of learning to observe, is as we think about people and trying to help them with medications, one of the things that's really been pivotal to us is just appreciating, and this picture we think does a good job of just noticing how when you're treating a whole person with their needs, that we think this graph is right, that only about 20% of those needs are directly a result of a medical condition or a medication. There are a lot of other important factors that affect the medication and medical condition, but they're related to the individual's health behaviors or the physical environment that they're in, whether they're homeless or not, for example, or the socioeconomic factors that they are experiencing or have experienced, such as what kind of income do they have access to, what kind of education did they have the chance to be part of. All of that factors into who they are, how they think, and what they're experiencing. And really only 20% we think is really related directly toward that healthcare event. And on top of that, then you have a very big thing that emerges called discrimination, which we all are more sensitive to these days for a variety of topics. And what that does is just makes those 4 areas of a human being that much harder when they're feeling like they're purposely not getting the attention they need in the way that they need it, and or feeling in any way, feeling like people not only don't care about them, but actually think badly of them. That just makes everything much more difficult. Now, what's not on this particular slide that's super important is underlying everything that we just told you, a person's life story and their experiences is almost even more profound in who they are and how they've been shaped. And so that's best summarized on the next slide about trauma. And so why do we bring up the word trauma to observe today? When you think of trauma, I want you to think of life-changing events that are physical or emotional and that are harmful. And they can occur once or they can occur frequently. And they forever change who you are. In fact, if a person were to tell you about that event, it would be very likely they would tear up or speak to you differently or act differently while they're trying to share you that life story. It's a very profound life event. And trauma separates itself into one type of trauma that we're all familiar with, like war or natural disasters, and there's been some of those recently with the hurricanes, etc. Or we hear about some wars that have been going on in the Middle East, for example. But really, it's just as profound on the left side of the slide on the personal and private experience, where a person may have experienced sexual assault, abuse, or domestic violence. And actually, that's been in the news lately in different ways. And so And then those are overlaid by the inequities culturally that I talked about earlier. These happen more or less depending on who you are and what ethnicity you might be. And those trauma events are so very important to who you are, who you trust, how you think. So interpersonal violence, when it's not a war or a natural disaster, when it happens from person to person, it really is extremely disruptive to an individual's sense of trust and attachment. So as part of responding to trauma, another way to say this is people's brains are rewired to try to cope with that traumatic event, and how they think about what you say and what you do and what they experience can be very profound, and they're constantly trying to understand, what are you trying to do to them? What are you thinking? And so one way to kind of help this, everybody listening to understand this, is the Adverse Childhood Experience Study out of California. The goal here really in this study was to figure out how prevalent trauma is for everybody, not just for disadvantaged people, so that we would have a sense when people have more trauma, how much more trauma do they have? And so it was a cross-sectional study in California about 18 years ago now, about 17,000 individuals, trying to figure out the prevalence of trauma. And what they did is they asked a survey of really bad questions to see what the prevalence is. And these are examples in the blue of the bad things. Experienced physical abuse, grew up with someone in the household that used alcohol or drugs, experienced sexual abuse, etc. Grew up with a mentally ill person in the household. You can see them here. The takeaway from this study, in a normal strata of people, if you're walking down the street and 5 people pass you, more than 2/3 of them, if you were to stop and get to know them and they were willing to share, would tell you of a really bad childhood traumatic experience in their lives. More importantly, 1 in 5 of those people you just walked past on that city block would have had 3 or more of these really bad things happen to them in their lives. That is pretty dang profound. In the Medicaid population, we think it's closer to 100% have had at least one really bad thing happen to them. So this is pretty profound stuff to really take into account, that people's lives are being shaped, the decisions they make, even the healthcare decisions are being shaped by these traumatic experiences. And when they took a look at this data over time, just like smoking, the more trauma, the more bad things you happened, the worse any disease or behavior was. So you smoked more, you used alcohol more, you were more likely to use drugs, your diabetes was worse, you had a greater chance of heart disease, suicide attempts were more frequent. It was definitely dose-related to trauma experience. And so there's definitely an association and cause and effect between trauma events and health. So what is the insight that we're learning around how to think about trauma and how to approach somebody whose life has been changed and has a trust issue? How do you be the right healthcare professional in that setting? And it has to do, and what we're learning is, it's not so much about what's not working for them, whether their medication is not working or their diabetes is not under control. It's more about what's happening to you right now, what happened to you in the past, how are you feeling? It's about getting in touch with them in the present and giving them the space to reveal who they are. Because the patient is often navigating trauma, maybe that trauma state is being triggered, and they have a trust issue, they're constantly in that fight, flight, or fear place. And so it doesn't take much to get their epinephrine going, and they're not thinking straight. They may use loud words, angry words over the simplest thing. And really what you're seeing when you see that is they're trying to tell you, I need you to hear what I'm saying, and they just don't know how to say it. So once the fight or flight is triggered, it's very hard for them to listen, retain information, process what you're trying to teach them or train them, or follow through on any great medical, behavior, or drug therapy plan while they're in that state. And this is where we get to the trauma triangle. I talked to a doctor whose lifetime passion was serving the Medicaid population in a clinic setting. And I asked him, what did he want me to know about how to think about caring for somebody when he sees them in their exam room? And he said, it's very simple. This is what I want you to do. Anytime you see a patient and you first say hello to them, I want you to be watching and thinking in the back of your mind, where are they in the trauma triangle? And I said, wow, every person, like, this is before I knew about the adverse childhood experience study that I just told you about, but he said every person, and he said, yes. They are constantly, I'm looking for signs of anxiety, depression, or post-traumatic stress syndrome, or all of the above. And depending on if they're in a triggered state, if they're complaining about chest pain, or their opiate is not working for body pain, those may be signs of post-traumatic stress or anxiety or depression. And they're trying to treat body pain with brain pain, when they're thinking it's body pain. So it's very important to watch for these things. And these bullets help you see the way in which anxiety, post-traumatic stress, and depression are manifesting themselves. But there's a more profound thing that happens with trauma. As you have trauma and because your diseases are worse, you suffer impairment that you or your doctor or healthcare provider spot. It creates risks that need to be dealt with, and your diseases start to worsen, just like I showed you in the previous slide. And what happens with that? More and more medications get prescribed. And then medications get prescribed to deal with other medications. And all of a sudden you have multiple pharmacies, multiple medications, multiple different prescribers involved with the patient. And you reach this important point the patient does in their life journey where it overwhelms them. And so we want to call that out and saying medications used wrongly to help people with trauma become a source of trauma. And so we're calling that medication trauma. Medication trauma is medication complexity and lack of coordination that overwhelms the patients, the caregivers, and the provider resources, creating fear, confusion, and error, which leads to poor adherence, compliance, and outcomes. And I'm hoping if you heard this for the first time, that you may help us discover this and do something about it, because it's happening way too often. So pearls, based on everything I showed you, is focus on the relationship first, not what needs to be done medically. Provide adequate time to listen and let the patient reveal to you who they are and how they're feeling. Seek the patient's point of view. Understand their context. Wherever you can, try to get as much information about their lives, where they are, what they're doing, and give the patient a sense of team that you're part of a larger group of people that care for them. Examples of the way providers are doing this in taking care of the vital signs related to social determinant gaps that are affecting this trauma, like they can't drive someplace, they're homeless, they're being abused, is to increase access to key health services and discover those, accompany a patient to appointments for context, make and discover referrals of how to get them to the right person, link them to community resources, help them connect things, and be part of that connection journey. The way we're doing it at CareOregon, because that's a bit of a complex requirement, is we've divided our internal staff into regional teams that can understand where those resources are in the local context. We can partner with clinics, and we can make sure that in multidisciplinary teams, we can increase the chance that the patient's going to get what they need and experience dignity, belonging, in a relationship by a group of people that cares for them. And I'm going to pass it over to my colleague, Paul.
Thanks, Jim. So one of the things in the course of our work that we have discovered very quickly that needs to happen is we're always trying to see if we can develop new tools that can do two things for our members: to engage them and ideally empower them. Because when you hear Jim describe the population that we're working with here at CareOregon, most of these individuals are used to feeling that they just are not heard, very often. They're being told what to do, they're being ignored or marginalized very often, and their voice is something that they're just not used to having be heard. And if we're asking them to follow complicated, heavily burdened medication regimens, there needs to be a way to get those folks to be a little bit more engaged in their medications. And so those are the kind of tools that we've started to try to work on. Because the typical member in CareOregon, we've got probably between 12 and 25 medications going on per individual. They have a very high medication burden combined with very often very low health literacy and very little support or time to understand them. And when you look at the way packaging will impact things, even like in the most generic circumstances, it's very easy for these folks to become confused by the huge number of medications they have. Particularly, we forget very often that most of the time, the indication for that particular medication is never even on the label. So you have folks dealing with a huge assortment of pills in front of them, then they're very confused about what's what. It leads into safety issues where somebody mistakenly could end up thinking they're taking their heart medication, but they're taking pain medication by mistake. So it's a bad recipe, and it's something we need to be able to impact and improve. So it led to us developing a tool that's become very popular within our patient population called the Meds chart. We wanted to be able to get a chance for folks to engage with either their providers or their caregivers and actually give them a chance to express what's going on with those medications. It's a simple tool. We will pre-populate it for folks so it's got a list of all of their different medications on there. The main purpose of this chart basically is to act as a catalyst for conversations between those individual members and their healthcare providers so they can actually find out what's really going on with that patient's experience with their medications and improve it. So we use a real simple, colorful, health literacy friendly Likert scale, smiley face, neutral, or a frowny face. How do you feel about your medications? And we find very often members aren't used to being asked that question at all. You know, I've heard a lot of patients say, I'm not used to being asked how I feel about my medications, but when you actually do take the time to ask them, it turns out they have a lot to say about it, and they've just felt they never would be heard before. So here's an example of what somebody might fill out on their chart. They feel good taking their anxiety medication because it helps them feel calmer. Or perhaps there's a diabetes medication that they don't like the side effect that's associated with that. So having a chance to actually express how they feel about those circumstances, suddenly that person's a lot more engaged around their medications, and they're a lot more likely to engage around them and commit to improving things. And we've seen those results, which leads us to a brief synopsis of motivational interviewing. Because if we're talking about a group of people who are seldom heard, and they're trying to work through complicated change processes, motivational interviewing is the ideal way to connect with folks, especially when they have a background of trauma going on, because change is really difficult. And if somebody's ambivalent about doing something like getting off of drugs, or quitting smoking, or losing weight, or being more committed to their medication regimen, and motivational interviewing serves as a great way to go ahead and start having those challenging conversations and make progress towards the kind of change that's necessary to improve someone's health. Motivational interviewing, you may have had some exposure to it in the past or haven't talked about it in a while, but it grew out of addiction therapy environments, and it's used in a number of different places now, including corrections and school environments, to help folks get a better handle on managing change in their life. The idea is very simple. It's basically just a conversation style, and it's one where you're not really providing anything to the individual that you're working with that they don't already have. Think of motivation as being a seed that's sitting there dormant within that patient for whatever it is they want to change. The ideal is that motivational interviewing, these conversations, become the water and the sun that help that person find out what's inside them that allows that seed to get light and germinate and move forward. The old school approach of just giving directive, kind of figure-wagging information is just going to suppress more dirt on top of that seed and prevent it from going anywhere. Back in the day, if you're doing, you probably still may know some providers and clinicians that like to give a lot of expository advice to the patient, and you're still expecting a person with that kind of trauma and that kind of literacy level to follow complex instructions, they're going to feel very defensive and be resistant. With motivational interviewing, you're doing way less talking in general. Actually, most of the talking is being done by the patient or the member because they're the best experts on their own individual circumstances. So just to use an example of a technique from MI that works really well would be avoiding closed-ended questions. If I'm a member with trauma and I go in a pharmacy to pick up my medications, and the pharmacist says to me, "Do you have any questions about your medications today?" I've just been given a hall pass to get out of there. I can just say, "No, I'm good," because it's a closed-ended question. Open-ended questions like, "What questions can I answer for you about your medication today?" You're going down the same street, you're just asking the question a different way. You're encouraging that individual to look within and to elicit their own thoughts. What do you think it would be like if you weren't smoking anymore? What do you think it might be time to quit using drugs? You can't just say yes or no to those things. You need to opine. You need to look within. And that's the whole point of motivational interviewing, is you're trying to generate something called change talk. And change talk basically is speech that favors any kind of movement that that person's starting to have in the direction of changes. So these kinds of example statements: "I wish I could quit smoking. I know I can lose 5 pounds. The reasons for me to stop doing drugs are my family, my children, my job." Those kinds of things are change talk. When you start to hear it, you want to encourage it, ask questions that help generate even more of it. And as change is a process, as most people know. You initially don't even begin to consider doing something like quitting drugs or quitting smoking or losing weight. And you begin in kind of a wish fulfillment desire place. You know, I wish I could exercise more often. I wish I didn't smoke all the time. And looking at the list of different segments of change here that are within change talk, you're kind of starting off very simply in that wish place of desire, moving downwards into a more tangible place. So you're going in the ability of someone going, "I know I can walk around the block twice a day. I know that smoking is going to lower my risk of getting cancer. I really need to stop doing drugs or my wife is going to leave me." Those kind of process steps lead to commitment. I'm going to make sure that I use a pill box every day to take my medications. And then actual tangible steps where action's happening. You know, I walked up the stairs today instead of taking the elevator. I went all last week without stopping by McDonald's. I had a nearly full pack of cigarettes and I threw them away. Those are tangible action things that make you know that that person has somehow been able to unlock that genesis of motivational interviewing to make change within themselves. So it's basically the idea, essentially, of how this works with the human brain, is if you can help somebody visualize for that individual along their values, what's that idealized future state place look like for you? Let's just pretend it's 5 years down the road. You're off drugs, you've fixed your problems, you've lost weight, everything is better. You no longer have diabetes. Let's not worry about how we got there. What does that look like? What's that idealized future like for you? And when a person can visualize what that belief-driven future ideal place is for them, that's a powerful thing. Because once that happens, if they then realize that there's a discrepancy between how they're behaving now in their current behavior and what they wish that idealized place in the future was like, we are programmed as humans to want to resolve that discrepancy. There's that breakthrough moment. It's that realization of that disconnect that happens. That's the power of motivational interviewing, and we've seen it work extremely well for folks. So now this is, by all means, a very abridged intro to motivational interviewing. I would encourage everyone to find training, and there's lots of resources that we can point you towards, even for like a simple fundamental intro to motivational interviewing that you can go and get a refresher on. But I'd encourage you to get more training on it, because you start to see that it's got tangible, evidence-based results. But until then, I wanted to just transition by showing you some simple tools that anyone can do without full-blown motivational interviewing that let you do what I like to call kind of drive-by MI, where you can basically be using the precepts and concepts of motivational interviewing in just daily engagement and conversations with patients. So just a couple of things that are along that same spirit. First of all, if you want to give information to somebody, ask them for permission. It may seem like a little thing. Would it be okay with you, Bob, if I gave you some information about places you can go for medication-assisted therapy to see if we can maybe help you with this opioid problem? Would that be okay? I'd love to give you some information about that. It may seem like a minor thing, but the act of asking for permission, it shows respect. It changes the power differential between you and the patient. And it's rapport building, which is a huge thing in motivational interviewing. So that's a little thing, but it actually can unlock doors in a wonderful, wonderful way. The second tool is what we call the magic wand. And this is when we were talking about helping visualize that idealized future for the individual they may not have spent enough time thinking about, where we say, okay, Susan, let's pretend that you've got a magic wand, and it's 3 years from now, and you've managed to get your diabetes under control, quit smoking, and you're exercising regularly, and you have a so much better relationship with your kids. Okay? Let's not worry about how we got there. But what's that like? We got a magic wand and you're there. Tell me what you think that would be like. And that person is suddenly given free rein to use their imagination to really clearly picture what that could be like down the road. And one of the last tools that I mentioned is very simple. It's basically helping a person assess their level of commitment to something and their amenability to change, which Jim is going to talk about a little bit more in a moment here. But it's something called the readiness ruler. And it's just a simple question that you ask somebody. You say, okay, let me ask you this question. On a scale of 1 to 10, how important is it for you to quit smoking and quit drugs or whatever it may be? And let's say the person answers a really low number, like a 3. Well, I say on a scale of 1 to 10, it's a 3. Maybe they're not quite there yet. So what you might respond to them is, says, okay, you said a 3. I'm curious. Why did you say a 3 and not a 1 or a 2? You know, don't do the opposite. And if you say, well, why did you say a 3 and not an 8 or a 9, kind of makes the person feel bad that they're not further along there. But by doing it in the reverse way and say, why didn't you choose a lower number? Even if they say 1, why didn't you say 0? Because then you're sort of getting the person to realize that they could have chosen a lower number and they're actually further along in their processing of maybe wanting to make a change than they even themselves realized. So it can be a powerful thing. And then the follow-up question is asking in the same way on a scale of 1 to 10, how confident are you that you can make this change? It's a little thing, but it's a great engagement strategy, and it has a magical ability to get a lot of good conversation started. Hand in glove with that would be that med chart we were talking about, because it's a great way to allow the individual to express themselves in a complex situation involving their health care that they're normally not given permission to ask. So there's just a few simple things about motivational interviewing that I think help explain why, from folks with a background of trauma, it's a powerful and extremely upbeat, positive tool. I'd like to pass it back to Jim now at this point, who'd like to continue our conversation.
Right. So now, with what you know, let's recap, right? And we're learning just like you are. If we've got a person and we're trying to treat the whole person, and we know that the medication and their medical condition is only 20% of the story, we also know that there's a really often dark story that's hidden. We know that if we can provide a tool like the meds chart or some other technique to get them to talk about where they are, what they want us to know, and what their emotions are, that we're going to uncover some important things that may not be related to medications or medical conditions. What do we do next to help this person on the journey to hope and healing? How do we create a situation that it causes this circumstance with Paul's magic wand to turn from a wish into a reality? What do we do? And so people have been talking about this word amenability. And amenability is watching for circumstances in people where it comes together that we can truly help them get to a better place. And the more people we can find that are like that, the more people we can help. And the only way that you're going to get there is with this picture, by putting the patient in the center and working as a team with all kinds of different skills. Because it's going to take a village, literally a community, and that's what these people need, is a community of help to allow everybody to work on partnering with them to close the gaps, whether it's housing or transportation or abuse or behavioral health support to help with traumatic events and how to think about those and how to cope with those. And you need a trained professional to unpack trauma. You should not ever on your own try to unpack trauma. They can tell you what they want you to know, but if you're pricking a bubble unintentionally or intentionally, they need professional help to keep that whole trauma realization to be a safe situation for them to be able to correctly deal with that. So that was my little sidebar. Be very careful. But you're providing the support, and you need to do it with a team of people. And so here's an amenable gem. If you think of 3 critical individuals as part of this team of people, just to help you see this concept, think about, depending where the patient is and their life needs, if they're experiencing a lot of pharmacy complexity, obviously a pharmacist is well suited towards that. If they're experiencing a lot of medical disease complexity and all the ramifications of dealing with those diseases, a nurse is an excellent resource. If they have environmental or behavioral complexity, people like social workers or behavioral health specialists, or there's even new fields called health resilience specialists, are excellent resources. And so what you're seeing by this picture is, depending on their most acute need, maybe it's better for one of these individuals to go first. Be that person who does the listening. And then bring in these other resources as part of a team effort. If all 3 of these are needed at once, and that's that center arrow that I've written on the slide, here's the gem. If you find somebody that has a lot of medical complexity, a lot of medication complexity, has a lot of environmental or behavioral complexity going on, and has been in the ER or hospital, it is most likely that where they are in their disease is not curing the disease, but coping with the diseases, and they're in that end of disease palliative care framework in which the thing to do to help them and to work as a team is helping the patient reveal what are their goals. What is most important to focus on right now, and simplifying their lives and their efforts around those goals so that that wish can come true. So it's all about goals of care, and it can be about palliative care. And that's a whole different framework of thinking. So that just illustrates the importance of working together with team members. And so I'll conclude by just summarizing up here that this arrow on the left shows you this continuum of disease and life healthcare journey, all the way from birth and then all the way to conclude with hospice. When we talk about Amenable, we're trying to catch them in that early phase of stable chronic disease where they and us are in the best chance of changing their life story. This is an excellent, excellent place to partner with them. But if you catch them later, like I just said with advanced illness, no problem, but that's where it's very important to work with a team. And so this is another way to say it. As you're trying to help people every day, you're going to be crossing people with a patient readiness where they or you are going to struggle to work together versus you're succeeding. They're in a place and you're in a place to succeed with that medication change, to support that medical condition. But also the people you partner with, the clinic, the hospital, the people that you know in the community that can drive them places or close the social determinant gaps, they're ready to partner with you. If the patient's ready and you're ready and the system resources are ready, then that's how you magically get to this beautiful place called Amenable. And so the more you can find of that or create that, the more success you're going to be with serving your patients. So in conclusion, Amenable is about realizing that a lot of this is not medical, and sometimes we try to medicalize a problem, and even medications can cause trauma now, inadvertently. The way of healing is an experience of hope, belief, trust, relationship, time. These are things that we all need to practice and find space for. It's about prescribing, not medications, but caring conversations. It's about de-prescribing and simplifying, taking away medications that no longer earn the place in that person's body to simplify their lives. So we started at this talk with learning how and to appreciate why we need to provide empathy and how to discover it. And we're ending this talk with where we want to be is the patient's able to experience empowerment because they're experiencing trust, that you're listening and they're experiencing that listening. We're finding out what matters to them. We're partnering in their journey to hope and healing. We can use techniques like the meds chart to just ask them very simple things about how they feel. And most importantly, and I want to echo what Paul said, any time you can give to build up your skills around motivational interviewing, you will be so happy you did it and so delighted in the effect with the people you're serving.